Hello, and thank you for joining us today. My name is Dennis Begos, and I'm an Associate Medical Director in the Department of Medical and Scientific Affairs at Nova Biomedical. Today, we have the extreme honor of Dr. Ravi Mehta here to discuss with us the 0x25 project. Ravi is a nephrologist and a professor of medicine at the University of California, San Diego, and he's a very accomplished nephrologist. He's the recipient of a number of NIH grants. He's the principal investigator on a number of clinical trials, and he's very well published in the areas of acute kidney injury, CRRT, as well as global health, which is why he's here today. He recently published a paper on the 0x25 project in PLOS Medicine, and we're going to discuss that in a little more detail with him today. Ravi, thank you for joining us.
Thank you, Dennis. It's great to have this opportunity to be with you and discuss a little bit about what we've been doing. I'm a professor of medicine at the University of California, San Diego, and have been on the full-time faculty here since 1988. My areas of interest have always been acute kidney injury, and I was fortunate enough to be one of the co-leaders for the International Society of Nephrology 0x25 project, which started in 2014, and I'll be glad to tell you a little bit more about it.
So Ravi, for those who aren't familiar with the 0x25 study, why don't you give us an overview, kind of a 20,000-foot view of what the study was about, how it began, what its origins were, and what its purpose is.
So the International Society of Nephrology 0x25 project started actually following a initial inaugural speech by the then president Giuseppe Ramuzzi in 2013. This was the ISN annual meeting was in Hong Kong, and he threw a challenge to everybody. And as you know, the International Society is an organization of nephrologists from all over the world, and it's and has had a long-standing interest in terms of trying to optimize care of patients who have kidney disease. And his challenge was that acute kidney injury, which is a acute decline in kidney function, which can occur almost to anybody. It's got no boundaries in terms of who it might affect or what it might do. You have it easily affecting people who have underlying comorbidities versus those who are otherwise normal and could in multiple settings. So anyway, his challenge was that acute kidney injury is associated with high mortality. And so is there a way that we could reduce preventable deaths from acute kidney injury by 2025? So this is 12 years ago in 2013 in June. And it was met with a lot of surprise and, not that everybody didn't know that this was a problem, but it was sort of, oh, well, now we've got to do something about it. So when we started thinking about this and initiating this, he tasked me along with another team of members to basically develop a project around this. And one of the first things we came up with was essentially to understand what would be the scope of a study like this and what would be the scope of a project like this. And so the first aspect was just to understand the lay of the land and recognize that what do we mean by preventable death? And when we think about preventable deaths in a situation like this, it's hard to fathom it unless you put some criteria around it. To put this in perspective, when you look at acute kidney injury, many people do not have a concept of what it really means. For instance, somebody who is in a motor vehicle accident ends up in the hospital, and during the course of their hospitalization, their kidneys fail. They were otherwise fully healthy with no other problems. Then the fact that their kidneys fail translates into them having not only a longer stay in the hospital, more chances that they would die, not only during the hospitalization, but also as much as 1 year to 5 years later from complications related to it. You could have other people who may have, say, underlying comorbidities like diabetes or hypertension, and they develop acute kidney injury. Someone in an environment may get a snake bite, and following the envenomation, get acute kidney injury. So there's this wide spectrum. So what we came up with was that there are three types of preventable deaths. First is where there is endemic illnesses which are correlated with or have a high risk for developing acute kidney injury. As I mentioned earlier, in the tropics, you might have patients who are likely to get a snake bite. You might have somebody who has got malaria, who has dengue, or they develop cholera. So those endemic illnesses are type of 1 type. And then the second level of preventable illness is in situations where we may miss the fact that somebody has acute kidney injury. It could be within the hospital setting, it could be outside the hospital setting. And it's not uncommon that we may not necessarily recognize the signs because the kidney itself does not complain. It's not unlike the heart where you have chest pain or a stroke where you have loss of, or neurological function. The kidney doesn't have any overt symptomatology, and you may only find out with some lab tests, or you may find out if the person really gets sick and gets complications related to the loss of function. So that's the second aspect of it is the preventable part is that you either missed the few changes which referred to or missed a lab, or that in essence we were contributing to it. So for example, a lot of patients need to get antibiotics. And some of those antibiotics have side effects on the kidney. And so while they are necessary, you do have a unfortunate effect on the kidneys itself, which could be missed. So that's the second sort of level. And then the third level was more where there is lack of care or lack of access to care. And that is because, let's say, in certain parts of the world, there is no dialysis capability. There's no capability of getting a lab test done. Or if there is, it costs so much that the person can't afford it. So we sort of started thinking is, okay, there are these three levels of preventable death. So how do we then define what we would do in this project? And so that was just the starting point for it.
That's great. Thank you, Ravi. And you mentioned that AKI can be like an MI. And just out of curiosity, when we see patients with AKI, many of them have a bump in their creatinine, a decrease in their urine output, and it typically, in many patients at least, resolves over a few days. Is AKI analogous to an MI in that once those patients resolve their AKI, they have a number of nephrons that are non-functioning, that are dead, or do those nephrons actually come back? What's the pathophysiology of AKI after they recover?
No, actually, Dennis, that's a good question. I think the way we think about acute kidney injury is that our criteria for identifying it are based upon either a change in urine output or a recent and a relatively quick change in the serum creatinine values, and the definitions are usually within 48 hours for an absolute change or within 7 days. And the intent and the expectation is that the acute kidney injury patient should recover. However, the recovery rates depend upon a variety of different things: the nature of the insult, how severe the process was, what was the underlying state of kidney health, and then how long it lasted, and how many episodes the patients had. So a significant number of patients will recover, but there are others who will not recover completely and may end up with chronic kidney disease as a result of that episode of acute kidney injury. So unlike, and in some ways, like myocardial infarction, I mean, you can have patients with myocardial infarction who will recover over time. and others who will succumb to that illness. It's the same thing with acute kidney injury. And part of this relates to what else is going on at the time that the kidneys fail. How many other organs are down? What caused it? Is it sepsis or any other aspects, which will all contribute to that outcome?
Thanks, Ravi. You mentioned a lot about low and middle income countries when it comes to the 0 by 25 study, and that's certainly where it was focused. But we know that AKI is not limited to low and middle income countries. Do you think that it's more prevalent there, or do you think it's underdiagnosed there, where people live in remote areas and may not have good access to health care or laboratory evaluations and things like that?
So Dennis, the first thing we did with the 0 by 25 project was to do a international study where we designed this. So it was run in September 2014 for 10 weeks. And we asked physicians from all over the world, from multiple countries, to basically pick a day in their daily lives where they would record information of patients that they saw on that day or 3 days prior and to who met the criteria for acute kidney injury, and then tell us what happened to them 7 days later. And we were very fortunate to have over 4,000 patients' information recorded, and we published this in Lancet. And what it showed was a very unique set of information as such. It showed that we were seeing a wide spectrum of where acute kidney injury was occurring. And to our surprise, we found that a significant number of patients had acute kidney injury in the non-hospitalized part in the community. And then they may have come into the hospital with it. And a second group of patients were having acute kidney injury during a hospitalization. So there was this distinction between community-acquired and hospital-acquired acute kidney injury. We found that dehydration, hypotension, and infection were the common denominators, no matter where you went in the world, which associated with acute kidney injury itself. And then we also realized that patients, depending upon which part of the world they were, had different levels of access to care. And so as a consequence of this, we recognized that patients who were in low and low middle income countries, whenever they presented with acute kidney injury or were recognized to have acute kidney injury, they were at a much more severer stage of acute kidney injury than those, say, in a very high income country where access to care was available. And then finally, we also found that patients who we would ordinarily dialyze in a high income country often were not dialyzed. And to some of this was related just to the fact that they couldn't afford it or that dialysis services were not available, which sort of reinforced our notion that we needed to think about the preventable deaths again in the same levels that I had shown you earlier, in terms of those where there are endemic illnesses and versus those where we miss the diagnosis or contributed to it directly to those where there's access to care. Because in each of those circumstances, the strategies to tackle it would be quite different in that setting.
Thanks, Ravi. So that's the feasibility study or the feasibility groundwork that was done. What did you guys then do next in order to further advance the 0 by 25 study? And do you think it's something that could have been done without technology such as handheld creatinine meters?
So the trial was designed to ask the question, could we assess the feasibility of an educational program in remote parts of the world where access to care is limited, for people to identify acute kidney injury and manage it. So the design of the study was that we picked 3 countries. We did Malawi, Nepal, and Bolivia. And in each of these 3 countries, we went out into the community, to the healthcare clinics in the community where there's no doctors. Patients are seen simply by some qualified individuals, but who do not have any formal medical training beyond, being able to assess some health systems. And we designed the study in 3 phases. So in each of these centers, we had a cluster of healthcare clinics, which then were reporting or sending their patients to a district hospital, which was then staffed appropriately with physicians and the ability. And yet in these clinics, there was no structure other than basic vital signs being monitored or basic aspect of care to be provided. And we had set the study into 3 phases. We did an observation phase for 4 months, a training phase for 2 months, and then an intervention phase for another 6 months. And in the observation phase, so from the data we had collected from the 0 by 25 study before, we created, one of my colleagues, Dr. Macedo, who is now also at UC San Diego, took that information from those 4,000 patients and created a risk score based upon a symptom complex. And we had identified in the previous 0 by 25 patients that patients who had acute kidney injury came in with a relative sequence of symptoms which were associated. They may have come in with diarrhea, they may have come in with shortness of breath, they may have come in with decreased urine output or other symptoms. So she parsed those symptom complexes and created a score which allowed us to say, okay, based upon how a patient presents to the clinic, and if they meet a moderate to high risk score based upon those symptoms, then we would do 2 things. We would take consent from them and to say, can we test your blood with a finger stick creatinine, which was the Nova Biomed sensor, and also a urine dipstick. And from that point onwards, then we would follow those patients for not only the clinic visit, but subsequently up to as long as 6 months. So in the observation phase, we were just collecting this data. Then we trained in the next 2 months the local healthcare providers. So we had embedded a research coordinator in each of these health centers, whose sole purpose was to do the test, responsible for gathering all the data. And then in the next 2 months during the training phase, we actually trained the actual healthcare provider themselves and also engaged a physician at the district hospital who would be accessible to care. And so that person could then provide guidance to the healthcare provider based upon what the test results look like. And then that was part of the intervention phase where we did the same thing, except this time the healthcare provider, if they recognized the patient had the high-risk scores, got the creatinine test, and got the urine dipstick, could ask the telemedicine consult, so to speak, from the physician in the district hospital. And to enable this, we had a cell-based, cell telephone-based program, which allowed the physician remotely to connect with by text messaging, and also they could see the data because the data was being uploaded directly through an app, which was Android-based and on a tablet, so that they could view it and see what was the basic information on the patient. And so that's the study that we utilized the Nova Biomed creatinine point-of-care creatinine test for, and that's what we determined. That's the results of which were published.
That's great. Thanks, Ravi. Can you talk a little bit about the results of the study? And also, what are your thoughts about whether the study is scalable or not, whether it can be applied to larger population groups, larger countries in these remote areas, particularly in low and middle income countries?
What we were able to determine by using these point of care instrument itself was we looked at the initial values, and then some of these patients were hospitalized, and then they're hospitalized. We did also values at 2 days, but otherwise we did values. They were followed up at 7 days, and then 30 days, and then 3 months. And what we found was that about 9% of the patients had underlying chronic kidney disease. These are all, you can think of all comers. I mean, this is over 2,000 patients. So 9% had chronic kidney disease underlying. And then within 7 days, which was a definitional aspect of acute kidney injury, 30% of the total population developed acute kidney injury or met the criteria of acute kidney injury. And approximately 57% of the patients from this enrolled group had what we call acute kidney disease, which means that definitionally they did not meet the criteria of chronic kidney disease, which requires that you should have a structural damage or evidence of changes in your renal function for over 90 days. And that, but they did have they did not have any history of chronic kidney disease. So they were classified as acute kidney disease. And in essence, what we found was that overall 30% of the patients develop acute kidney injury. And then when we tracked them downstream, the overall mortality was about 13% in them. But we were able to track based upon the sequential testing that we were doing as to what happens to these patients, both in terms of their follow-up versus their going into the hospitalization, what happens post-hospitalization. And what was not unexpected, but was somewhat, it was not unexpected, but we had hoped that it'd be a lot less, is that we lost a significant number of the patients to follow-up. And part of this is because some of these patients had to travel long distances to go to be seen in the hospital or even to the healthcare center. So for them to have to come back and see, that was not quite easy for them. And I think so given what we found with that aspect of things, what we think is, yes, it is feasible to train and equip people to monitor kidney function with simple tests. A point of care instrument for creatinine and a urine dipstick helps you identify those patients who might benefit from it. I think what's more important, though, is to have a awareness that acute kidney injury is there and is something which needs to be addressed because it has a lot of downstream effects. And more important, that this needs to shift into more policy issues because the accessibility of these devices or even the ability to train people to utilize them comes more at a cost for other things. So imagine for a moment that in these healthcare centers, people are seeing 60 to 100 patients in one day. So you don't have the luxury of time of saying I've got 15, 20 minutes per patient, which is kind of the norm in most of the high-income countries' clinics as such. When you're seeing 60 to 100 patients a day and you've got one provider or maybe one provider, one helper, and these are not people who are physicians, then somebody has to enable them to give them the resources to do these tests and to follow up patients and to have the accessibility. So yes, it is scalable, but it requires, it will require that there is a concerted effort from the government or the local policymakers that they perceive that this is something which needs to be supported and they provide the infrastructure for it.
Thanks, Ravi. That's great. You actually anticipated my next question, and I'm going to put you on the spot a little bit here and have you put on the hat of a minister of health in a low and middle income country. So if you have a limited budget, limited resources, do you think implementing something like the 0 by 25 program is something that would be cost effective? Because as you mentioned, there are lots of downstream costs and morbidity and mortality associated with AKI. Do you think this is something that would be worthwhile for countries to pursue who are in situations like this?
I think that's a very difficult question because you're competing with a variety of other illnesses, which things. So when you think about where you have level 1 countries, the equivalent of that, you don't have the resources, you don't have access to care, you're fighting things like malaria and dengue and tuberculosis and malnutrition. And in that context, to say, well, put all your resources in terms of identifying acute kidney injury, that's probably not going to meet the same level of priority at a government, at a level itself. Too much, even in an upper middle income country, we don't spend as much time and effort on trying to detect acute kidney injury or manage it itself. I think probably the best example of what's happening in the world is from the UK. Now, with the UK, with the national health system in place, they started in 2009. They realized from an audit that they did that acute kidney injury was a real contributor to downstream effects and mortality and problems. So from 2014 onwards, they did a national audit. And in fact, Dennis, at the meeting that you were in shortly earlier last week, our AKI and CRT conference, Nick Selby showed some of the data from the UK audit, demonstrating that they mandated that everybody in the hospital, every lab, would report on abnormal creatinine values which correspond to acute kidney injury, and they tracked it, and they tracked what happened to them, they tracked what the preventive measures were done. So that at a national level, and they've already demonstrated that that made a difference with respect to downstream aspects, and he had shown the health economic benefit of that intervention. When you translate that into a low and low middle income country, or even a middle income country, you've got to put this in context of what else are the competing events which are happening. Nevertheless, I think that by raising awareness of this, by focusing on what's preventable, I think those elements can be implemented and should be implemented. And that's something that we need to continue to strive towards.
Well, that's great, Ravi. So do you have any take-home messages for folks who are looking in here who may be in situations either in low and middle income countries or in places where there's an under-recognized or under-diagnosed population of folks with acute kidney injury?
I think the most important aspect here is the continuing need to raise awareness, provide the tools to individuals, and continue to take the small steps which are necessary to make this happen. The International Society of Nephrology is focused on, as is now the American Society of Nephrology. They have initiatives in place, and we are making a lot of progress in terms of how to identify the disease, how to manage it, how to treat it. It's one of those major areas that we will continue to need concerted focus on. So the more we can do to identify individuals early on and manage them, it'll make a big difference to outcomes.
That's fantastic, Ravi. Thank you so much, and thanks for being part of the team that's able to help raise awareness of this significant worldwide health problem and this global health problem that hopefully we can begin to address through technology and through projects like the 0x25 that you've been spearheading. Hopefully we can help put a dent in this significant healthcare problem across the world. Thank you.